more people will trickle in. This is a very popular time between morning patients and afternoon patients. So I'll just go ahead and give a background about myself and the MAX program. So my name is Bridget Sweeney, and
their pregnancy, and they compared them to also second trimester aborted fetuses that did not have cannabis exposure in utero, and they found a dose-dependent difference in the number of dopamine receptors in the brain. And so in utero cannabis exposure seemed to be directly linked to dopamine receptors in the brain. And so I don't, depending on my patient's health literacy, I might not specifically explain there's dopamine receptors in the brain and they were dose dependently affected by the amount of cannabis that a woman used in the second trimester. The way that I describe it is just, that cannabis, when you use marijuana, that it affects the way that you think and feel. And while your baby's brain is developing, it can also affect your baby's developing brain. And so there's a risk to that. And I just, for most people, leave it at that unless they have more questions or they do have a higher health literacy and want to ask more specific questions about it.
Dr. Mark, we do have a question. I'm sorry to interrupt.
Sure, that's okay.
Do the birth weight risks depend on mode of use, for example, smoking versus edibles?
So that's a great question. We actually have almost no data about the differences in mode of use during pregnancy, because a lot of these modes of use are much more recent. They've come about in the past decade, and there's really not a lot of data inside or outside of pregnancy about the differences of risks, which actually kind of leads to my next slides about the risks of use of marijuana. Most of these known risks are things that were studied in relation to inhaled use. We don't really know a lot that's different about if it's different with different routes of use, particularly like edibles and tinctures and things like that. What I tell women is that other than the respiratory effects, I don't anticipate that there's going to be differences, particularly in pregnancy, because the idea is that you have this circulating THC that you've absorbed, and so whether you inhaled it or absorbed it through the GI system, I would imagine that the effect on pregnancy would be the same. The truth is we don't have that data, but I have no reason to think that it would be different biologically. One of the big differences in the routes of administration is how quickly somebody experiences the effects. So inhaled and vaporized have the most rapid of onset, and oral administration has a much slower onset, but they're still having the same absorption. Well, depending on their level of use, they're still having absorption of THC, the psychoactive component, into their bloodstream. And so I would assume that would affect the developing fetus in the same way.
Two more questions trickled in after that explanation, which was great. Do you have any data or studies that show the percentages of ADHD in kids whose moms have used marijuana during pregnancy?
There is actually, I'll have to find it and I can send it to whoever would like it. There was a recent study that tried to link ADHD and cannabis use together. It's an incredibly hard thing to study because the genetic factors of ADHD are very hard to control in those circumstances, because you would have to choose parents who did, or you would have to know the parents' background, because we know that there's a very high heritability of ADHD. So there's so many things that we've tried to link both ADHD and autism to, and there's so many confounding factors that are really hard to assess and control for in those studies. So my short answer is there's not a known direct link between those two things. I think that there are relatively high rates of co-occurrence, but that is very confounded by genetic factors and the fact, again, that women with any mental health disorder, including ADHD, have a higher risk of cannabis use to begin with. And so then it may be that their baby develops those disorders because they were genetically predisposed to them, not necessarily because of the in utero exposure. So I can't say either way, but there is no known direct link.
Great, thank you. And one more question for right now. Are the risks based on daily use of marijuana? Most moms report using about once a week for nausea. Is there any research around this?
There is not, but yet to be determined, because there are some ongoing studies now that are trying to look at different routes of use and different levels of use, because this, again, is one of the methodological flaws in most of these data, is that they view use as binary, like used or did not use. They don't talk about the trimester of exposure. They don't really talk much about the amount or how frequently. There are a couple of studies that seem to think, particularly there's one, it's called the Generation R study that looked at growth throughout the pregnancy and trimester of exposure, but they don't talk about like daily or multiple times a day or weekly or monthly. They just talk about trimester of exposure, and there did seem to be a higher risk of growth restriction in using in second and particularly third trimester. And then there was another study that was recently published that looked at women who used before or after they recognized their pregnancy, which pregnancy recognition, we all know it could be later, and it could even be like late second trimester, but women who continued use after recognition of pregnancy had higher risk of adverse birth outcomes. So we think from the very limited data that we have that continued use throughout pregnancy is worse, but really basically no studies have looked that much at the differences in how frequent use happens. And so you're all hitting on very good points, which come across in our counseling to patients, that there are a lot of things that we really don't know. But again, likening it back to other medications that are other things that people can be exposed to during pregnancy, we don't have that fine tune of data for a lot of stuff that people expose themselves to during pregnancy, right? And so I counsel women categorically not to eat sushi in their pregnancy at their first prenatal visit. We don't have that much data about sushi, and most people that eat sushi have absolutely no problem in pregnancy, but I can just categorically say, don't eat sushi, and nobody questions that. But when we talk about cannabis and the things that we do know about it, then everybody wants much more fine-tuned data. And I want it too. I'm certainly not saying that these questions aren't valid. They're absolutely valid. But I think that this comes across in our counseling to women sometimes, that when we start to get into the, well, we don't really know if it's 3 times a day or once a week that's a problem, it's then that comes across to them that we don't know, and so it's fine. And that their conclusion becomes it's okay because we don't really know the answer. So these discussions, these intellectual discussions, are incredibly important amongst groups like this. But my recommendation for counseling is that you come up with a few kind of black and white counseling, things that you want to hit on in your counseling. We know that THC can affect the baby's brain development. We think that it can also affect the baby's growth as well. And these are the potential, those are the potential issues that you can have with use during pregnancy. And now I am going to talk about medicinal use, and then it's going to sound like I'm going the opposite direction and saying it's actually all okay, but it's risk versus benefit again. And if somebody is using recreationally, just like I tell you, stop using all alcohol, the truth is we all believe that having one glass of wine during pregnancy probably isn't going to hurt anybody very significantly, but why take the risk, right? And so that's kind of the way that I describe it to women that are using solely recreationally. And I'll get a little bit to my specific recommendations about counseling in a few slides. So the other thing that I want to point out is that during counseling of pregnant people who use drugs, particularly cannabis, but all drugs, we often focus so much on the baby. And I always take a moment during my counseling to talk to the woman as a human being and not just as a mother, because cannabis has risks in a non-pregnant person too, right? And so this is important both because I want her to recognize that I see her as a human and not just as a vessel with a baby, but also because I want her to recognize the potential risks to her inside and outside of pregnancy, because there are incredibly high rates of relapse back to cannabis and all drugs postpartum. And I think at least a part of this is because we focus so much on why you should quit because you're pregnant and not why you should quit for your health overall. And I also think that counseling of, focusing so much on the pregnancy just sort of devalues women's overall health in general. And so trying to empower them to want to be healthy for their own sake, not just for their pregnancy, I think is important. So just to go over a few health risks to any person, that pregnant or not, of marijuana. There are, it's sort of a misconception that people cannot be addicted or get a use disorder from cannabis. That's not actually true, although there aren't classic symptoms of withdrawal, like with opiates and things like that. There are some less recognized symptoms of withdrawal, and addiction and use disorder are certainly possible. It actually happens to about 9% of users and 1 in 6 users that start in adolescence. They can have impaired driving. There are respiratory differences, which I actually kind of outlined in these next few slides. The effects on the brain are decreased attention, concentration, speed of information processing, memory, and associative learning. And so this is important to anybody, but I also talk to women about relapse postpartum, and you're already fatigued, sleep deprived, maybe depressed, having postpartum depression, and then you're trying to take care of your baby. You also use cannabis on top of that, and it's going to make you have a slower reaction time and all these things that could cause effect to you or your baby. Other maternal effects and increase of cannabis-associated psychosis, and so we know that cannabis use and drug use in general is very linked to mental health disorders, and it can actually precipitate psychotic episodes. There are a lot of contaminating substances that can be in cannabis, fungus, heavy metals, things like that can be ingested and can be harmful to women. There are pulmonary effects that are known, including acute bronchodilation. It actually used to be used for asthma exacerbations initially before people really understood it. And it causes acute bronchodilation, but then long-term it causes airway obstruction. And so when people initially use it, at the very beginning, they may actually feel like they're breathing well, but over the long term, particularly with inhaled, it can have some respiratory effects. Maternal effects are that it causes vasodilation and tachycardia. It can cause orthostatic hypotension, which can be confused with just something that happens in pregnancy. So people are telling you that they're feeling dizzy all the time, they're seeing stars, and they stand up and they feel like they're going to black out. That may just be pregnancy, but it also can be certainly exacerbated by cannabis use. There's an increased cardiac output with no increase in blood pressure, so that can be a strain on the heart and also cause this hypotension. And there is a small but real increased risk of myocardial infarction because of these cardiac changes. So knowing all these things about the risks during pregnancy and just health risks in general to women, why do we think that people do continue to use during pregnancy? Because we know that at least a quarter of people that use at the beginning of pregnancy continue to use throughout pregnancy. So why is that? One of the reasons may be that women don't understand or believe the risks, and that's something that we certainly can help with if they don't know what the risks are, or they don't really believe that there are any risks. We can help with education. It may be that they understand the risks, but they have a cannabis use disorder. And if that's the case, then they need intervention and help. And that is something that's under-recognized, I think. And then it may be that they understand the risks, but they choose not to quit because the benefits for them of cannabis use outweigh the risks. Even if they know what the risks are, they feel that the benefits outweigh them. And that may be for recreational use, but a lot of times that actually is more in the medicinal realm where they see that their benefits are outweighing their risks. So this is a slide that is showing information from the National Survey on Drug Use and Health that shows that women who use cannabis during pregnancy were more than twice as likely to report that their use was medical than women that use it outside of pregnancy, saying that if you consider your use to be medicinal, then you're more likely to continue to use during pregnancy. Women who use cannabis during pregnancy were also 1.5 times more likely to report that they had a cannabis use disorder. So women who are pregnant are, as I said in the past slide, are more likely to be using medicinally and also more likely to have a cannabis use disorder. Those two things can be separate, usually are separate. And they also were almost 7 times more likely to say that they needed help. They needed treatment for their cannabis use, but unfortunately they were no more likely to actually be referred to treatment or have any formalized treatment. They just said, yes, I'm trying to quit. I can't, I have a use disorder. I need help. And no one gave it to me. I'm not going to go over the very specifics of this, but it'll be in the slide if you would like it. This is the DSM-5 criteria for how to diagnose a cannabis use disorder. It's very similar to most drug use disorders in that women are unable to quit. They have consequences of their drug use. They are using more despite trying to cut back. They're getting less of an effect, although they're using more. So tolerance, dependence. And the treatment for cannabis use disorder is really behavioral interventions, including cognitive behavioral therapy and motivational and enhancement therapy. And every provider does not need to be well-versed in how to do these. You just have to know that that's the next step and then be able to refer women for this treatment. And of course, if you don't know how to do that, you can always reach out to Max for Moms and we can help you find treatment. So as sort of a preamble to talking about the medicinal use, this also goes back to what I was talking about before about how we sort of overestimate the risks of illicit drug use, and we really often downplay the risks of medicines that we prescribe. And so somebody had mentioned that a lot of women say that they use it for nausea and vomiting, and women tell me the same thing. But we have to remember when we're talking about medicinal use that we in the medical community have a pretty bad track record of telling people that things are safe in pregnancy and then finding out later, oops, sorry, we didn't actually study those things, but now that we've used them on a lot of women, we know that they're a problem. And so, everybody I'm sure is familiar with some of these medications that were previously used and then found to be incredibly teratogenic or have very negative side effects. And we'd like to all believe that that was in history, but this recently happened with Zofran. And although I think that this was, personally, I think that the studies on Zofran were very overblown. And I think that the risk was overemphasized. I also think that that comes from this sort of medical distrust that happens in the community from the history of a bad track record of the medical community. And so, when we tell women, don't use marijuana, use this medication that I'm going to prescribe you. They're like, hey, you told my mom that she could just take DES or she could, and she would be fine. And, look where she is after her thalidomide. So I think that we have to come into it with the understanding that people are going to be a bit skeptical of what we're telling them. This comes from a letter to the editor after a study that was published in JAMA about women continuing to use cannabis and the risks of cannabis in pregnancy. And the title of it was Why Pregnant Women May Justifiably Choose to Use Cannabis. And the quote that I picked from it was, the implicit idea that naive pregnant cannabis using women require education is pejorative and paternalistic. Perhaps these women recognize that with no federal standing, quality medical research cannot be conducted on cannabis. Gold standard randomized clinical trials are effectively illegal, and what data we do have on cannabis does not show definitive harm. So I think that last sentence is a bit overstated. I do think that we have enough data to say that there is certainly at least biologic plausibility for harm. But I think that when we're counseling women, we have to keep in mind that our counseling about the risks of it is not, it doesn't always come across as them, as us caring about them as pregnant people and wanting to educate them. They may be like, I know all of this and I don't believe any of it. And so, and then in that case, I think it's very important to talk about their benefits of use, which we're going to get to in the next few slides. So I'm sure that everybody has had somebody tell them in their medical career that they use cannabis medicinally. So there are some known medicinal benefits of cannabis that have been studied and fairly well documented. So these things are things like glaucoma, nausea, although I will say the caveat to that is this is specifically nausea that is related to chemotherapy. It has not been well studied or really studied much at all in nausea and vomiting of pregnancy, which may be different physiologic mechanisms. And AIDS-associated anorexia and wasting syndrome, chronic pain, inflammation, multiple sclerosis, epilepsy, anxiety, PTSD, sleep disturbances, and spasticity. So these are the things that have some reasonable evidence that it may be helpful for them. Cannabis has really become kind of a catch-all for a lot of people to say like, oh, I use it medically. Like medically for what? Is the important question, because there may not actually be any medicinal benefit to what people think that they're using it medically for, but then there are other things that legitimately have some evidence to them. So medical marijuana for pain, this is one of the more common reasons that people tell me that they use it. The important thing to know about these studies is that it was mostly neuropathic pain that was being treated. Most studies used between 1 and 10% THC. The highest study was 12.5%. And the reason that people don't use higher than that is because when you get above 10%, people complained of a lot of psychoactive changes and negative side effects from it. Between 1 and 10% was much more helpful for pain without having all of the side effects that were undesirable for people that were legitimately using it medicinally. The problem with this is that the average dose in medical dispensaries is about 13%, which is higher than what anybody recommends for pain. And they go as high as 37% in medical dispensaries, which is just outrageous. Nobody medically needs 37% THC for anything ever. As far as nausea and vomiting, of course, this is the most common reason that people tell me that they use cannabis during pregnancy. There have been many studies that show that women who have nausea and vomiting in pregnancy are more likely to use cannabis. So there's an association there. There have been no studies that look at the actual benefit of it. And for a long time, I tried to tell women this, and I still do try to tell pregnant people this. And their response is, I don't really care about the studies. I know it works for me, which you have to roll with that and understand that, their experience is valid. And just because I don't have a study that proves it doesn't mean that it's not true for that person. And this is certainly being peddled by the pharmacies. And so unfortunately, medical dispensaries are really not regulated, and the people that work there do not have to be any sort of medical professionals. Typically, they are not. In this study, they called all of these medical dispensaries in all of Colorado, and 83.1% of the medical dispensaries recommended use for morning sickness. They called and pretended that they were a woman having morning sickness and said, "Do you recommend it?" And almost all of them recommended it. There are some confounding factors about whether or not it works during pregnancy, because I don't know anybody, well, I can name very few women who have told me in all of my years of practice that they started using marijuana during pregnancy for their nausea and vomiting. Typically, they were using it before, and then they become pregnant, and then they try to stop using it, and they feel nauseated, and they think, okay, well, I'm just going to use cannabis because I know that works for my nausea. And so the question is that actual treatment for it? Is it some sort of withdrawal symptom? Is it cannabis hyperemesis syndrome? There are a lot of, sort of confounders there to see if it's really the marijuana that's treating their nausea and vomiting. So cannabis hyperemesis syndrome is, it's underreported, although I more frequently see it as like the hot diagnosis that everybody wants to blame on nausea and vomiting. It really happens in people who use chronic daily cannabis. It's not in your casual users that are using once or twice a week. It's in people that use cannabis very frequently. It alters their endocannabinoid system, the HPA, and the hypothalamic pituitary axis, and changes their response to stimulants. And so it's classically happens when people are using they're using cannabis chronically, very heavy uses, and then all of a sudden they start to get very bad GI discomfort, and they have nausea and vomiting. A lot of times you'll see that they will have this pathologic bathing behavior. They want to be in a hot shower all the time because that helps them feel better. That's very pathognomonic of cannabis hyperemesis syndrome. And the treatment for it, there are a lot of things that you can do to help mitigate the symptoms, mostly antiemetics, benzos, Haldol, things like that. But really, it's just cessation of marijuana, and usually it goes away within a week of complete cessation of marijuana. Although if they return to use, they're probably going to return to having the hyperemesis. And oftentimes you'll also see that people changed dose or changed route or something around the time that they started to have the severe nausea and vomiting. So this is how I approach my screening and then counseling. When somebody discloses their cannabis use to me, this is sort of part of the SBIRT. I always try to figure out what are you gaining from it? What are the benefits that you're getting from your cannabis use? And within that answer to that question, I try to determine if it's more medicinal or more recreational. Because if you just ask people, do you use medical marijuana? Most of the time they think that you're asking them, do I have a medical card? And let me tell you, having a medical card does not categorically mean they're using it medicinally, because you can buy a card pretty easily. And not having a card definitely doesn't mean that they're not using it medicinally. So getting to the underlying reason as to why they're using it is extremely helpful for any type of counseling about any type of drugs, but particularly for marijuana, because just like any other medication that somebody's using, when they get pregnant and I tell them they have to stop their Depakote, I don't just say stop your Depakote. I say that's not safe in pregnancy. Let's find an alternative for you that's better to treat this underlying condition that you're using it for, because it's not, that condition is going to get exacerbated, or they're just going to return to use because they're going to be frustrated if you don't treat the underlying problem. So the first step is determining if it's recreational or medicinal. If it is just recreational, purely like they use it for fun, they use it for relaxation, socialization, that type of thing, then finding out if they have a use disorder. And the slide that I explained what a use disorder is, you can refer back to that. And if they do, most people are going to need a little bit more than a brief intervention if they truly have a use disorder, and they can be referred to cognitive behavioral therapy or MET. If they don't have a use disorder, then oftentimes just a brief intervention, scheduling follow-up is going to be enough to help. And I'm going to talk about how to do that in just a minute. If it is medicinal, then figuring out what the underlying cause that they're using it for is, and then determine, does cannabis actually treat that thing? And is there some other alternative that we could use? So the most common thing is nausea and vomiting. Great, you're having nausea in your first trimester of pregnancy. Let's use all of these other methods that we can try and see if those things can help with your nausea and vomiting. And then we can maybe cut back on your cannabis use. Because if they're using it for that and you just say stop, but you don't treat their nausea and vomiting, they're not going to be successful. And sometimes I get to the point in this deep dive in the counseling and the screening questions where I find out they're using it for something and there either isn't an alternative or the alternative is questionably safer than marijuana. So my best example for this is that I have a patient who used medical marijuana for her migraines. And she went to her neurologist when she got pregnant and said, hey, I want to be off my marijuana. It worked great for me outside of pregnancy, but now I'm pregnant. What can I use? And he said, here is oxycodone. And she was like, I'm not using that. Like that has more risks, in my opinion, than cannabis does. And so we had a conversation about it. And truly the end of that conversation was, okay, you know what the risks are of cannabis use. You can't live with your horrendous migraines during pregnancy and you don't want to be on chronic opiates. So, okay, you're going to use cannabis. But that is something that there is actually evidence that it's helpful for. She had been prescribed or recommended marijuana before. And so most of the time throughout this algorithm of counseling, I can get to safer options and helping them to really identify what their use is and the best ways to decrease their use. This is a slide that I don't want you to get too focused on exactly each one of these things, but this is from a recent survey that I've done in my own patient population to find out about women's reasons for use prior to and after pregnancy. The blue is reasons for use prior and the red or the orange is reasons after they became pregnant. And the point that I want to point out here is that this question about why you're using is not just a one-time question because it changes throughout pregnancy. And people may have used prior to pregnancy for some totally different reason. Then they get pregnant, their motivation changes, you've convinced them that it could be harmful, and so they want to stop. And now they try to stop and they're having trouble sleeping, or they're nauseous, or they find their anxieties out of control. And so now their reason for use actually switched. And so your counseling and your treatment actually may need to switch. And so particularly when you do your initial brief intervention, you come back to your follow-up and people are still using, making sure that you re-ask those questions about, okay, what are the benefits of your use now? Why are you using now? Because that is not a static answer. So brief intervention, this could be a whole hour talk in and of itself. But in a brief intervention, you want to understand the person's views. What are the pros and cons of their use? You want to give information and feedback. So we talked about the medical risks, and you don't want to assume that, just like that person was saying, that you don't want to be pejorative and assume that pregnant women don't know anything and you have to educate them. I usually start out by saying, what do you know about the risks of marijuana in pregnancy? And a lot of times people can like read me the book back and tell me things that aren't even risks that they believe are risks. And so, if you start out with sort of a lecture view of like, you don't know anything, let me tell you why it's bad and you're hurting your baby, then that's not going to be as good of a therapeutic audience. They're not going to open up as much. So I usually start out with that question of tell me what you know about the risks, and then expand upon that. And then assess their desire to change, their motivation, and see where they want to go from there. Some people start out incredibly motivated. Some people start out not motivated at all. And you have to kind of assess their readiness to change before you can decide what the next steps can be. You want to give advice and negotiate a goal. So negotiating a goal, I think, is incredibly important, and people respond well to this. So instead of just saying marijuana is bad, don't use it, you go through this whole counseling process and discussing, their risks and what they see as benefits, and then say, so what are your goals for your use? And if they say, I don't want to quit, then okay, is there anything we could do is there anything that you might be able to do to help decrease your risk a little bit? So the goal is not like in the research studies, it's binary, all or nothing, you use or don't use. There are lots of harm reduction things you can do, like using less frequently, particularly to try to help decrease their use. And if you're not ready to stop, are there any changes that you might feel ready to make, taking baby steps? and progressing towards your goal, but not just saying like, this is my goal, that is your goal, we're miles apart, we're never going to get to the right place. Just taking small steps if they're ready to. And then the most important thing is setting a follow-up. So just talking about it one time is never really the answer. Coming back and circling back around at your next visit. And so I usually say, I don't want you to feel like everything that we talk about is your cannabis use during pregnancy. There's lots of other things we're going to talk about, but is it okay if we circle back at your next visit and talk about this again and just see how you're doing with your goals and how I can help you get to where you want to be? So as I said before, it's very important that we provide information and feedback in an unbiased way. We want to provide facts, but we also want to admit when the harm is unclear or unknown. So overstating facts does not come across well, because most women do have some education about this, and saying we categorically know that this terrible thing is going to happen, your baby's going to be autistic because you're using marijuana, those things come across as very judgy, punitive, and they can see through it. They know probably that that's really not true. And so admitting when there are some things that are unclear, but still having your firm recommendation, I think is important, because we have to admit that we don't have every single answer. Provide information in a non-judgmental way, and don't focus your counseling on the legality of the substance. And so I do think, and I have a slide coming up about this, but I will talk about the reporting requirements, and I am honest with all of my patients about that. But what you want to be careful about is that you use that to improve your therapeutic alliance and say, look, I need to tell you everything, and this is the truth. And if your baby's positive at the time of delivery, or whatever your hospital's rules are, we will have to report you to CPS or DSS. But let's see what we can do to get you negative by the time of delivery. And that's actually not the reason I want you to be. It's because of all these health things. So making sure that your counseling isn't coming across as, I want you to stop because it's illegal, because that's not useful for several reasons. One, because most of the time it's not actually illegal anymore in most states, and they're like, well, who cares? It's going to be legal in a couple years anyway. Secondly, because as healthcare providers, really we should be focusing on healthcare issues, and that and kind of staying in our lane is, I know there are a lot of social workers here too, and sometimes the legality things are your lane, but making sure that we're saying like, I care about you as a person, not just you're bad because it's illegal. Motivational interview strategies. I know I'm running short on time, so I'll just go quickly through this. Expressing empathy is important. Quitting any sort of substance use is incredibly hard, and so just recognizing that and saying it out loud. Developing discrepancies between where the person wants to be, what their goals are, and what their current actions are. So a good example is, you've told me that the most important thing to you is keeping custody of your baby. And I agree, that's incredibly important, and I want to help you get there. So how does your cannabis use fit into that? Is a better way to talk about the legality than like, you're going to get in trouble. Roll with resistance when they're like, I can't possibly stop. You don't want to argue. This isn't a wrestling match. You're leading them in a dance instead of trying to wrestle them and pin them down to the mat and say, this is what you have to do. So, ask, recognize the struggles that they've had, and ask if there's anything that we can do to help them feel more confident in their change and help support self-efficacy, so that they really feel like they can change. Just a few words about marijuana and breastfeeding. This is a commonly misunderstood thing. So THC can transfer to the breast milk. And this is oftentimes viewed as like, okay, then you can't breastfeed, which I don't think should be the conclusion of the fact that THC is transferred to the breast milk. The concentrations that are transferred into the breast milk are 0.4 to 8.7% of what the maternal ingested dose was. And on average is about 2% of what mom ingested is present in the breast milk. And then the baby, remember, is taking that orally. So it is getting oral exposure to 2% of what mom inhaled, and oral bioavailability is very low. And so the baby really probably isn't processing that much of that at all. There are no studies on absorption, but what we know from absorption in adults, if you're taking 2% of what someone else took inhaled, but you're taking it orally, you're going to get almost no effects from that. And so the AAP, the American Academy of Pediatrics, said that street drugs such as PCP, cocaine, and cannabis can be detected in human breast milk, and their use in breastfeeding mothers is of concern and are contraindicated. And a lot of people took that to mean that breastfeeding was contraindicated in women that use drugs, but really it's the other way around. Drug use is contraindicated in breastfeeding women. So we should counsel breastfeeding women not to use drugs, but we shouldn't say if you're using cannabis, you cannot breastfeed, because the benefits of breastfeeding far outweigh the very, very infinitesimal potential risks of THC exposure through the breast milk. And then, sorry, I know I'm over time, but just a word about reporting. Everybody always has this question for me. So marijuana and substance exposed newborn reporting. Unfortunately, marijuana does remain federally illicit, even if it is medicinally or recreationally legal within states. It doesn't much matter because CAPTA goes by the federal laws. So CAPTA is the Child Abuse Protection and Treatment Act. And it says that in general that babies that are newborns that are exposed to illicit substances have to be reported, and there are nuances of that by state and by hospital. But even if someone has a medical marijuana card, that is not federally recognized, and so it's still considered illicit. So I can prescribe somebody opioids and their baby can be positive for opioids and they don't get reported. But if I recommend cannabis to somebody and I even sign their medicinal marijuana card and they get it legitimately from a medicinal dispensary, they still are reported when their baby is positive because it's not federally recognized. And so this is really, I'm not trying to necessarily comment on the DSS system in general, but what this points out to me is that this law is very, that the mandates are very focused on legality and not harm, because there are other things that are known to be incredibly more harmful to babies that are not reported. But the illegality of this substance is really what makes it have to be reported, which is frustrating. So in summary, cannabis use in pregnancy is common. Universal screening in pregnancy is recommended. Acknowledging a positive screen and providing medically relevant information is critical. Ignoring a positive screen can do more harm than good. A pregnant person's reasons for use should be elicited in order to tailor the counseling, and that should happen several times throughout pregnancy if they're continuing to use, because the reasons for use can certainly change. Refer to substance use counseling when cannabis use disorder is identified, and when use is medical, seek alternative treatments and consider risks of an untreated disorder if there are no other options for treatment. Thanks everybody for hanging in there a couple extra minutes, anybody that's still here. I'm happy to take any questions if there's anybody left that still wants to talk, or I'm also available by email if anybody would like to reach out to me.
Thank you so much, Dr. Mark. And I can't emphasize this enough. Please feel free to put your questions in the chat. Even if you have to log off, we'll be sure to follow up with you. We are grateful that Dr. Mark is able to stay on for a couple extra minutes here. We do have one question. How can one address this issue when mom is not open about her usage? She may have been referred due to a positive tox, but does not talk to the home visitor about it.
So I can speak, I'm sorry that I can't intelligently speak so much about home visitors, because I don't actually know what your interaction with people in their home is. As a healthcare provider, like in the healthcare setting, first thing I want to say about testing is that it's illegal to test without mom's consent. So I know this isn't your question, but I just want to say for anybody that's still here, it went to the Supreme Court. Drug testing in pregnant women without consent it's illegal. It's against the Fourth Amendment, their right to privacy. And so anybody that is getting testing should know beforehand. And so then when it comes back positive, that conversation should be a little bit easier because they already know they were getting tested. And there are pluses and minuses to testing, but there are some studies that show that testing, when women are being tested, they are more likely to report their use because they know that it's going to come out in the testing anyway. It is really hard when somebody comes to you after a test and you weren't the person that was talking to them about prior to the test, because in my own practice, I always explain to women when they're going to be tested, or when I would like to test them and the reason for testing, and then have that conversation in advance. And so then if it comes back positive, it's typically not a surprise to anybody because we've already talked about it, or at least it's an easier conversation to say, hey, I know your test was positive. You had said you weren't using, let's talk about this discrepancy, like what's going on, not to catch the person, but to try to elucidate what's going on. And I just focus in people that aren't open with me about their use, and for some reason I know they're using, but they won't talk to me about it. I do a couple of things. One is explain to them the reason that I want to talk to them about it. And so most of the time they think that I'm trying to talk to them about it to get them in trouble if they don't want to talk to me, or that I'm going to judge them. And so I explain to them, as a physician, it's easier probably than a home worker, but I say, my goal here is to get you as healthy as possible and to have the healthiest pregnancy as possible. And so the more information I know about you, the better. And then we can talk about the best way to get you to be as healthy as you can be. And if they still won't talk about it, I change the subject, talk about other things, and wait until they're ready to talk about it. Because you really, at least in the medical setting, it's impossible really to force anybody to talk about anything. You're not going to get good information if they're not ready for it. And so then after we've had we build more of a relationship and a rapport, then oftentimes they'll open up about it later. But I apologize, as a physician, it's kind of hard for me to give as much direct advice about how to do it as a home worker, because I think that women have a very different view of home workers than physicians, because I can say, like, my goal is to get you as healthy as possible, but I think a lot of times they're going to immediately view you as suspect and somebody who's trying to take their baby away and be very scared of you. And so I think, just highlighting any benefit that talking to you about it could bring to them.
Great, thank you so much. We just got another question. What is the harm for secondhand smokers or family member use?
Sure. So we don't know as much about that as we do about tobacco smoke. I mean, we know the respiratory and cardiovascular issues can happen with secondhand smoke of tobacco. We don't know as much about cannabis secondhand smoke. We do know that you can absorb some of the THC, and there are some studies that look at, like, people in not well ventilated areas, that they do absorb some of that THC. And so I think that the way that I typically explain that counseling is that you are going to absorb some of the substances that can be harmful. It's not as much as if you're smoking it yourself specifically, but it is definitely possible that you could absorb some of it. And so if your partner or someone else that you live with is regularly using cannabis, then I would just ask them to go outside or be in a place where you are not, so that you're not inhaling it and don't have that risk. And I don't have this exact information. There are some studies that I know that Hopkins Bayview has a specific lab that does this type of research, which is very interesting. But to see how often somebody's going to have a positive tox test because of secondhand smoke, and it's not that common. I get that answer a lot when there is a discrepancy between what somebody's telling me and their toxicology testing. They'll say, "Oh, well, my partner uses, and that must be why." And it's actually not that common that you're going to have a positive test because you were in a room where somebody else was using.
Dr. Mark, thank you again for staying on for a few extra minutes. There's due time for one more question. Would you prefer to follow up with this separately?
Oh, I'm happy to.
Okay, so this last question is, any suggestions for approaching or speaking to providers about this subject or screenings, especially for doctors who don't do this in their practice or are reluctant to speak to their patients about it?
Sure. I think that I said this at the beginning, but one of the most common reasons, the two most common reasons that providers tell me that they don't screen is that they don't really understand, or they don't either believe in or understand the harms. I showed that study where they asked women about what information they were getting, but there's also a study where they asked doctors about how they counsel people. And the title of the study is something like "Everything Above Marijuana Takes Precedence." And they were like, I don't know, everybody smokes weed and there's not really good data about it, so I don't even know what to tell people. So I think giving people some of these little talking points of some of the risks, like I said, I always tell my patients that it can affect your baby's developing brain. It affects your reaction time. It can affect your mood. And it also can cause issues with blood flow. Or we think it can cause issues with blood flow, which is why it would cause changes in the baby's birth weight. And so those kind of talking points, just to say these few things, can help people be a little bit more comfortable, because they don't want to screen because they don't know what to do with the results. And so giving a little bit of information about, these are the things you can say if somebody does disclose their use, or these are the ways that you can approach that. And then also, I think very importantly is knowing where to refer, which is again, a plug for Max for Moms is a big part of our goal is to help people feel comfortable talking to women in their practices about substance use. And we know that one of the big problems is that people are afraid to ask the question because then they don't know what to do. They don't know what the resources are out there to help women that screen positive. And so if providers don't know where they can refer patients, that's what we're here for. And we're happy to help make those connections or answer those questions or help them in those ways. So I find that most people, it's not that they don't care. It's just that they don't ask the question because they don't know what to do with the results of it. So, and also it helps some people just to say ACOG says it's standard of care. So, I mean, that's much more like kind of punitive counseling. Like you're not doing what your professional society says you should, but then it's sort of like the same thing, like you're doing motivational interviewing for them. Like, why is it you don't do it? And then you elicit what their barrier is, which oftentimes is either knowledge or understanding of referrals.
Great. Thank you so much, Dr. Mark. I think all these questions are proof that today's presentation was great and engaging and really important. Of course, the Max for Mom slide is up. Please keep us in mind as a free resource. And if you do have any extra questions that come up for Dr. Mark after today, please feel free to email those to us and we'll be sure to get those answered and turn that into a consult call. Other than that, we also just have our contact info up here. We have other events coming up, so be sure to look out for that. If you cannot stay on with us any longer, please feel free to log off. If there are any other questions that come up, feel free to put them in the chat now. Dr. Mark, we did just get one more.
I saw that about the visual. That it's a very good point, and there actually is a psychiatry resident that I believe is working on that exact thing, and so hopefully we'll have something that we can send out to everybody within the next couple of months. Because I agree, having just a little, I mean, we have posters everywhere about like what tobacco smoke does to pregnant people. And so I think having just like a couple little sound bites and visuals would be really helpful, because again, this is why alcohol is easier to explain, because everybody's seen a picture of a baby with fetal alcohol syndrome, but the changes with cannabis are a lot more nuanced. And so it's harder to say like, this is the thing that's going to happen. So having patient-friendly handouts, I think would be really helpful. So we'll work on that.
Awesome. Well, thank you all. We've gotten a lot of great feedback in the chat as well. So thank you all for your time today. We won't hold you up anymore. And Dr. Mark, thank you for your extra time for all these great questions. If we missed anything, which we may have, because there's a lot going on in the chat, I'll just be sure that we follow up with anyone. But other than that, thank you all for joining us today, and we hope to see you at other Max events soon.
Thanks.
We do have one more question.
Oh, okay.
What screening tools do most OBGYNs use? And sorry if that was answered before.
Oh, that's okay. We use 4Ps in our practice, which is the parent, partner, prior pregnancy questions. But really, truthfully, there are a few that are validated in pregnancy, but just using any screening tool, I think, is better than none. We chose that one because it is very well accepted among the patients and the providers. Our medical assistants just hand it to people at the beginning of their first prenatal visit, and then we go over it. So, I think my short answer is anyone is fine, but the 4 or 5 Ps plus, I think, are the easiest ones to use.
All right. Great. Thank you so much. I think that is official. Everyone, you will get a copy of the slides for those of you who are still on. You should get that by the end of the day. Other than that, thank you all for joining us, but we are out of time now. So thank you again, Dr. Mark. Please feel free to log off and I'll let you know if any other questions trickle in.
All right. Thanks, everyone.